everyone, I'm Dr. Neha Verma. I'm the co-founder and CEO of IntelliHealth, and our mission is to deliver quality healthcare where there is no doctor. I come from a little bit of a different sector. I come from the not-for-profit social impact sector. Using the word NGO can sometimes throw people off because the word NGO is not always synonymous with quality, or with the word technology. But our goal is to improve health access for the millions and millions of women who live in rural India today, who, if they have a simple health issue, are not able to get the kind of care that they need because they have to travel far, they may not have money, they may need permission, they may need to take a day off from work, and their daily wages being missed is the difference between eating food that day and not eating food that day. So our goal, half the world's population lacks access to essential healthcare services. 60% of people in India today live in rural areas, and access to quality healthcare is a basic human right. But today, if I am someone who is from a low-income background, when I go to a government hospital, am I really getting quality care? Is it quality care if I am sitting on the floor waiting for hours for a doctor? Is it quality care if I get just 2 minutes with that doctor? Is it quality care if I get a scribbled prescription which I cannot even understand? So we are working to change that through telemedicine, the use of information and communication technologies to provide healthcare at a distance. Many of you may have used telemedicine during the pandemic or even before the pandemic when you picked up the phone and called your doctor, sardi khasi ho rahi hai, what do I take? We work in different parts of telemedicine, not just direct to patient, but our majority of telemedicine is provider to provider, where we connect the ASHA workers, community health officers and nurses at government rural primary care clinics with district hospitals and private hospitals. So what we have is a technology platform and implementation know-how. So how is it that we're able to use technology to improve the quality of care? We work with about 1,700 doctors, almost 1.6 million teleconsultations a year. And it's through three portals. One is connecting a frontline health worker with a doctor. So the patient is sitting with that frontline health worker and interacting. And the second is through a helpline, so calling a number, maybe they are at home, they have COVID, they're not able to travel. And the last is an app where they can book an appointment, do a video consult. It's much lesser used for the population that we work with, which is primarily rural, may not have a smartphone, may not have that digital agency. So the first and most important measure for improvement of quality that we had done was technology. So today when you go to a doctor, when I go to a doctor, the doctor will ask some questions. Okay, pet mein dard ho raha hai. Since when have you had that pain? Is it more in the morning? Is it more in the night? Is there something that aggravates it? Is there something that relieves it? And these kinds of essential questions and data is what drives the diagnosis of that physician. But now when you put that physician in an impossible situation where they have 50 patients waiting in an OPD of 2 hours, how is anybody going to be able to practice quality care under these enormous time and resource pressures? And the same thing happens in a teleconsult. If I have a long list of patients who have to provide a video consult to, how am I going to do that? So what we did was we task shifted this process, standardized this process of history taking through extensive clinical protocols, over 100 different clinical protocols, all built into an application with a very simple user interface. So it interacts like a chatbot, like asking you the questions, it collects your responses, and it turns it into a clinical summary, a note. Not only is that helpful for the physician to make a quick and a better, more accurate diagnosis, all that data is amazing for the quality team to take a look at, to understand the prescribing practices, to understand how it is that the consultation is progressing. So not only that, the protocols are in different languages, almost 15 different languages, and there are analytics and visualizations. Of course, the cornerstone of improving quality, training, because technology can't solve for everything. Human beings have to be continuously trained, so we work on high frequency, low dose training, small nuggets of training, but at high frequencies and high repetition, because we are mainly working with healthcare workers like ASHA workers who haven't had a class 10 education either. So when you're thinking about how do you get them to practice care in a patient-centered manner, in a way that is consistent, making sure they're always washing their hands, using the medical equipment correctly to say measure blood pressure, it is constant repetition. So we have a whole module of course on training, and then finally on operations, again bread and butter, SOPs, guidelines, but making sure that it is continuously being followed and reporting and monitoring for feedback. So a few years ago, we set ourselves a goal, which is at the very least, the diagnostic accuracy of the telemedicine consult should be similar to an in-person consultation. That's a tall order, because when a physician is seeing you in person, they are able to touch you, they are able to visually see your gait, they may be able to be doing more physical exams, but when the patient is remote, it adds an additional level of complexity. The patients, what they are saying, their history becomes the largest part of your ability to make a diagnosis. And then whoever is that healthcare worker next to the patient, their ability to do a proper physical exam instead of the doctor doing the physical exam, those data points are the most important way for you to make a diagnosis. So that being the objective, we needed to first understand what is the current quality of care in consultations today. There's a lot of research that shows that there are millions and millions of medical errors that happen in India today, and it results in preventable deaths, it results in preventable morbidities, and the best, a focus on patient safety is really important to prevent all of this. So we developed a clinical quality index. It's a tool, a scoring system with a max score of 100 with 47 clinical indicators. So the QR code is something you can scan to download the index itself, but it has 47 clinical quality indicators across 7 domains. And the domains are adherence to standardized processes, patient-centered care coordination, safe clinical practices, patient satisfaction. Customer satisfaction is the cornerstone of quality, of course. Completeness in data collection, quality of the consultation itself, and quality of the program implementation. Because the quality is not necessarily a function of people, it is a function of process, and that is one of the most important cornerstones. So in total, you have a score of 100 that can be achieved. So just for example, patient-centered care coordination as a domain, you can get a score of 16, and if so it has certain domains. For example, the patient was made to sit comfortably and be calm before the consultation. Consent was taken every time. Consent about how their data is being used, consent about being to touch them, to see certain signs. The adequate privacy was maintained. It was done in a closed room with a door, a curtain. It sounds very basic, but in a government healthcare system, even these basics need to be kind of reiterated upon and improved upon. The medications that were prescribed were generic medications, because again these are patients who do not have the capacity to pay as much. So these were kind of the scores. So the CQI is administered by a quality team, and it has 2 components. One is direct on-site observation, where they will go quietly and without the health worker or anybody knowing that this is somebody who's come from the quality monitoring team, is seeing the consultation happening and is marking a score, 0 if it was not followed, 1 if it was partially followed, 2 if it was completely followed. So it's also administered in a simple manner. So this is one set of quality metrics through direct observation of consults. And the second set of quality metrics were from the data that is generated by the platform. So this is not related to direct observation, because you also want to look at if somebody is conscious of being observed, you will probably get the ideal case. But in the quality of looking at the quality through the data was another place that we worked on. So for example, did all the presenting symptoms correctly entered? Was the medication given correctly with correct dosage and schedule? Was there antibiotic overprescribing? Was the right amount of antibiotics prescribed? So all of that, again similarly, score of 2, 1 or 0 gives you a complete quality score, and with a max of 100. Now, like I said, the key elements, direct observation, electronic health record data, but the most important one is a participatory approach. Especially in the medical field, working with doctors on quality can be sometimes an issue that is mired in ego or mired in additional concerns. So the approach has to come from the clinical team itself, from the doctors that are a part of the process, from the health workers that are a part of the process. So very much so there is a participatory approach to this clinical quality index as opposed to a punitive approach to the clinical quality index. And it is not again intended to be punitive. The goal is continuous learning, continuous training. So as a result of what happens at the end of finishing this, and let's say a project or a particular clinic received a lower score, it goes back to the training team to incorporate into the training and learning programs for all of the staff who are working in those particular health centers. So there is a feedback loop on continuous training and learning. What's next? We are working with some really cool academic partners exploring the role of generative AI. Raise your hands if you have asked ChatGPT something in the last few months and you've been surprised at how accurate ChatGPT was, and you're wondering whether your job is obsolete after ChatGPT. But very much in the healthcare industry as well, the role of AI can be very important in improving quality of care. Simply put, there are never going to be enough doctors to meet the needs of the population today, and especially so in rural areas where there is absolutely no doctor to be had. So can basic health issues be diagnosed, treated and managed completely by AI? Is it a pipe dream or something that we will see in the next 5 years? So we did some proof of concept work on gastrointestinal issues, and interestingly found that ChatGPT was 80% of the times correct and similar to a doctor in diagnosing the root cause of a gastrointestinal issue. And also about 70% correct in recommending the right treatment plan. Of course, is that the right measure? No, we would want technology to be correct, more than 95–96% of the time. And there are, of course, regulations around AI that still have to move forward. But in the future, the doctor of the future will be supported by artificial intelligence, whether it's looking at your images and looking at different aspects of say your eye image to recognize whether there's a cataract, or maybe you'll be able to do it on your own phone very soon, looking at your camera, putting your finger on your phone camera to measure your pulse, or looking at a video to measure your blood pressure. So those are all measurements and advancements in the field of AI that very much have relevance in healthcare quality. This is my last slide, so just closing here. The most important thing for us has always been rooting any aspects of quality care into core values of patient safety and dignity. And again, it goes back to the dignity of that woman. It goes back to the person who today does not have the capacity to pay, which unfortunately translates into, if I don't have the ability to pay to go to the private hospitals, I am stuck with the things that are of low quality, which should not be the case, because quality health care is a human right for each and every one of us, and especially so for women living in rural India today. So thank you very much. You've been a lovely audience, and I really appreciate your time.
What percentage of the cases were accurately diagnosed? And are you also capturing morbidities of the patients? Because I didn't see the results slide. Anything on results?
Okay. So on the results section, we have a couple of clinical evaluations that we have published online. This is along with the government's for the eSanjeevani telemedicine project that the government has done. Are we able to see the thing with clinical quality and healthcare quality is that it's a continuous process improvement. And what we are able to see is that whenever we implement this clinical quality, what we have found is that in 70% of the cases, this was a study in Jharkhand, the results from Jharkhand, the doctor was able to provide the accurate prescription and accurate diagnosis. In the remaining 30, they were not able to provide a prescription or a diagnosis, and in those 30%, instead of providing a diagnosis, in about 20% of the cases, a referral was provided, which is an okay outcome, but in 10% of cases, an inaccurate diagnosis was provided, where ideally either a referral should have been provided or an inaccurate diagnosis, or an accurate diagnosis should have been provided. So that kind of sets us with a benchmark. Now, in a million consultations, 10% is a very big number, because every misdiagnosis is a big cost to the healthcare system and to the patient. So that was kind of one example, and then therefore, then you can drill down into the data a little bit more to understand what was it that was resulting in this. So one thing that we identified was physicians were finding it hard to recognize multi-drug resistant TB. Why is it that this TB patient, in spite of being on the DOTS program, is not able to improve their care? And so they're not changing the DOTS therapy because, and likely this is because the patient has drug resistant TB, which means that their tuberculosis is not going to get better with this set of drugs, or multiple sets of drugs. So things like that will then, feed back into a clinical training for the physicians. There's a wonderful program, again by the government, called Project ECHO, which again focuses on improving quality of care through continuous training and learning for physicians. So that's like one example, but this happens in each and every one of the projects where there's an output result and then you look at the score. The other thing, I feel like maybe I could show a couple of the slides. The other aspects of quality. Quality again isn't just about accurate diagnosis. It's also about patient-centered care. Was I spoken to with care and compassion? Was that prescription explained to me? Did I get the medications that I need? So again, in the same project, 87% of the patients got the medications that they needed. The remaining did not, because those medicines were not in supply. So again, that's a feedback loop to go back to the stock and supply chain or department to make sure that those particular medicines are improved in supply. So those are some of the metrics. I hope I was able to answer your question.
And do you capture death rate as well?
We mainly work into primary healthcare. We are not working in secondary or tertiary hospitals. So at that level, these are all primary healthcare conditions. So it's not about mortality, it is about morbidity.